Following is Dr. Alexander Cole. He's going to address a year in review, the top 5 clinical trials in focal therapy.
Thank you very much for the opportunity to give this talk this morning. I'm going to mostly be summarizing what I think are the top 5 clinical trials with a small amount of editorialization. These are my disclosures. I do have some proctoring fees from EDAP, and I'm going to be discussing Focal 1 in a couple of these trials. Going through, starting with number 1. I didn't realize you were going to be sitting here when I put this up here. This is the multi-institutional study of magnetic resonance ultrasound fusion-guided nanoparticle-directed focal therapy for prostate ablation. This is an open-label, single-armed, multi-center trial of gold nanoparticles. Men received an infusion of gold nanoparticles, laser excitation of these particles, and then monitoring with fusion biopsies, focusing at the region of interest. 3 months, 66% had a negative biopsy. At 12 months, 73% were disease-free at the site of ablation. Why does this matter? Why is it interesting? Well, this is the first in-human feasibility study of laser treatment using this new nanoshell localized laser therapy. I did notice something when I was going through this paper, and this is one of my minor editorial points. There was some heterogeneity in the outcomes based on the site where this was performed. And this actually gave me a flashback to 2016 when I wrote these 2 editorial articles about the Yaxley randomized trial of robotic versus open prostatectomy. And at that time, we spent a lot of time arguing about the fact that there was a 5-time difference in surgical experience between the robotic prostatectomist and the open prostatectomist. And we talked a lot about this. When you're comparing surgical interventions, and focal therapy is a surgical intervention, we need to think about how this is done and how we do standardization. I always think about the CREST trial of carotid endarterectomy versus stenting, where they had a credentialing process for the surgeons. Precision, which we all know, had a credentialing process for radiologists. I think it's something to think about as we go through these trials. Number 2 is a randomized trial comparing focal ablation and radical prostatectomy in patients with unilateral clinically significant prostate cancer. This is the Norwegian randomized trial that was presented at a podium, 2-year follow-up at the AUA this year. Focal ablation was performed with HiFU Focal 1. TULSA, radical prostatectomy, was performed with unilateral nerve sparing. And then failure was defined as radical treatment for those men who had focal ablation, or biochemical failure for those men who had radical prostatectomy. 107 men were randomized. 26, this is interesting, 26 men randomized to RP chose to have focal ablation, something to keep in mind as we design these types of trials. Failure rates are shown there, 6.5% focal ablation, 75% in RP. This was designed as a non-inferiority trial, and focal ablation was non-inferior. Trial number 3. This is HiFU versus radical prostatectomy for localized prostate cancer. This is an image from the presentation of HiFi at the plenary of AUA in 2024. This clinical trial was a non-randomized, nationwide study. It was performed in 46 French centers comparing HiFU versus radical prostatectomy. This was funded by the French Ministry of Health. The number of patients included is very high, as you can see here. Grade group 1, grade group 2, PSA less than 15. The primary endpoints, this is maybe worth mentioning very briefly. This was salvage treatment-free survival. Salvage treatment for focal ablation was triggered by a 4-cause biopsy after focal ablation. Salvage treatment after radical prostatectomy was triggered by biochemical recurrence, positive surgical margin greater than 3 millimeters, or pathologic stage T3B or higher. And it was designed and powered to be a non-inferiority design. The median follow-up reported was 30 months. The salvage treatment-free survival rate was 89.8 in the HiFU arm, 86.2 in the radical prostatectomy arm. This p-value is actually, I think, the superiority of the HiFU arm. It's not a non-inferiority p-value. As you all know, a non-inferiority p-value, you want the numbers to be bigger. But actually, this was a large multi-center trial. It led to subsequent approval in France, Switzerland. These are the survival curves for salvage treatment. HiFU is the blue line, radical prostatectomy is the red line. Seems like HiFU actually had a superior salvage treatment-free survival rate in the HiFi trial. This was the non-randomized trial. I think we need to think about confounding. They did do some adjustments, which are the dotted lines, but still think about confounding. And we need to think about how we're designing the endpoints because it's not exactly a one-to-one comparison. The next two trials are in progress. This is PRESERVE, which is the SUO Clinical Trials Consortium multi-center trial led by Arvin George and Dr. Coleman. These are just the preliminary results which were published earlier, or not results, but recruitment and treatment results that were published in Cancers earlier this year. 17 centers sponsored through the SUO Clinical Trials Consortium. Enrollment began in 22, ended in July 2023. Preliminary results published earlier this year. There were 121 individuals that received IRE treatment. There were relatively few grade 3 adverse events. There were no grade 4 adverse events. Why does this matter? This is a collaborative US-based study. This is sponsored by the SUO. This is, I think, a direction we should be moving in for these sorts of clinical trials. Number 5, this is also a clinical trial in progress. This is the PART trial, partial ablation versus radical treatment. This is led by Professor Hamdi, Rich Bryant at the University of Oxford, funded by the NIHR. This is the registration number here. This is not the final results. This is the feasibility trial that was published in 2018, demonstrating this, the enrollment criteria, randomization plan. This is a prospective, multi-center, parallel group, randomized, controlled trial. Radical treatment groups include radical prostatectomy, radiotherapy, and then the partial ablation groups include IRE and HiFU with the companies listed there. The first patients were randomized in mid-2023. There are currently 42 patients recruited, and the study is actively recruiting at 6 sites in the United Kingdom that are listed here. These are the first HiFU procedures done on PART. This is the counter listing the current recruitment. And some very brief conclusions and takeaways from these 5 clinical trials. I would highlight that the scope of these trials show a logical progression from smaller first-in-human type studies to larger non-randomized multi-center trials and culminating in large multi-center prospective trials that are generally sponsored by national research organizations and ministries of health. And I would also like to highlight some challenges in designing and executing clinical trials for focal ablation. I think thinking carefully about selection, randomization, it's challenging to do it's basically impossible to do allocation concealment for these types of clinical trials. And then another thing that I feel is very important to consider is the role of surgeon skill and experience in these types of clinical trials. I feel these are surgical techniques. Surgeon experience and skill is very important. And when we're designing these trials to create results that are going to be generalizable, I think we need to think about how we can do these at high volume centers in ways that are going to then be generalizable to real world practice. Thank you very much for the opportunity to present these trials. Appreciate it.